or PCI. Aliquot plus P2Y12 inhibitor is better than you use combination together without aspirin. So without aspirin added, you will reduce the bleeding risk and fewer hospitalization, and without significant difference in the incidence of ischemia event than the regimen with the standard vitamin K antagonist plus aspirin or both together. So after we review these three studies, so the question will be, how about new anticoagulation in the stable coronary vascular disease compared to the aspirin, added aspirin or not aspirin? So this is a clinical trial in 2017 called the COMPASS trial. Same things, group population is around 68 years old, the majority is white population, and let's see. The endpoint of this study is try to see the bleeding risk. So the major and the minor bleeding risk, compare the Aliquot plus aspirin looks higher than you use the Xarelto alone. So major driven by this is the non-fetal and symptom bleeding in the group with aspirin compared to without aspirin. And intracranial bleeding is less if you use the aspirin and compare you not use aspirin. This is why I don't understand this result, but looks like the number is very small. They said there is no significant difference with this group. And the primary outcome of the cardiovascular death, stroke, and the myocardial infarction, the Xarelto added aspirin is better than the Xarelto alone. So if you see the different age, sex, race, and the body weight, all appreciate the Xarelto with aspirin group better than you use the Xarelto alone. So this is aspirin group, this is the Xarelto alone group, this is the combination. Looks like the major primary efficacy outcome is better with the Xarelto combined aspirin for the stable coronary artery disease patient. So the conclusion is, among patients with stable atherosclerosis vascular disease, those designed the Xarelto 2.5 milligrams twice a day plus aspirin had better cardiovascular outcome and more major bleeding event than those assigned to aspirin alone. Xarelto 5 milligrams twice a day alone did not result in a better cardiovascular outcome than aspirin alone, and result more major bleeding events. So when you use for the stable coronary artery disease patient, for the anticoagulation, probably to use low dose, decrease the Xarelto dose to half, to 2.5 might be better than you give the true full dose. So this is just the meta-analysis for 4 different studies try to explain how the new anticoagulation agent combined to the Waffling plus the dual antiplatelet trial. So this is where we discussed previously, Pioneer, Redo, and August. So this is a very small amount, 570 cases with the West. So we not discuss today. So from this multi-analysis random trial data shows all the group, TIMI major bleeding, and the TIMI major and minor bleeding, and intracranial bleeding is all favored. The group, the reference, standard reference is Waffling plus dual antiplatelet. So all the things is study combine this. And then the different group is, one is the vitamin K antagonist, Waffling plus single antiplatelet. new anticoagulation agents with dual antiplatelet and new anticoagulation with single antiplatelet. So most of them to show that every combination in the group, this study group, is beneficial for the bleeding compared to the standard warfarin plus the dual antiplatelet treatment. And also you can see from, this is very unclear. This is a cardiovascular death. This is the stroke. And this is the hospitalization. So compared to the cardiovascular death, it's beneficial. And stroke is also beneficial, and hospitalization is also beneficial. But with in-stent thrombosis, you will see single new anticoagulant agents plus single PY212 antagonist. You probably increase the risk of in-stent stenosis compared to the dual antiplatelet treatment. And this is called the Sukrat numbers. The more high numbers, the more beneficial compared to TIMI, major bleeding, and efficacy outcome with all cause of death, MRI, stroke. So majority you can see bleeding benefit is the single antiplatelet plus a single new anticoagulation agent. And for the MRI, prevent MRI looks like traditional vitamin K warfarin, antagonist warfarin plus dual antiplatelet is better than the other group. So in the end of the, what is the answers? So from all the study and clinical trial, we know that new anticoagulant agents with single P2Y12 might be enough for most patients with AFib and acute coronary syndrome plus PCI. Either you use Eliquis 5 mg twice a day, dabigatran 11, 110 mg or 150 mg twice a day, Xarelto 50 mg one day or 2.5 mg twice a day, plus a dual antiplatelet for this smaller dosage with Eliquis group. And if you added aspirin on top of warfarin or compared to the warfarin alone, there is no benefit for added aspirin, but increase the risk of bleeding. And if you temporarily discontinue anticoagulation or P2Y12 in the patient with AFib and for PCI, you will increase the risk for ischemia event without reducing the risk of the bleeding during the procedure. So probably no reason to stop it. So next the topic we will move to the quickly. Do I have time? Okay, quick about this. This is a fourth study about new anticoagulation in a valve disease agent. So the first one is the Pradaxa versus warfarin in the patient with mechanical heart valve disease. So quickly, this is called real-aligned studies. It's a phase 2 trials to see the patient with mechanical heart valve randomly designed to receive a Pradaxa and warfarin post the procedure and see which is the one benefit. So this is a smaller group, only like involve 170 some cases, because this study is stopped in very early disease because it showed a very high risk and no benefit for the Pradaxa group. So you will see with the Pradaxa group, the group A is the patient involved in the study. We started the Pradaxa about 7 days after the procedure. The group B group is the patient previous 3 months ago already has a valve replacement and then involved the study. And you will see the group involved the post-valve, mechanical valve procedures group has more deaths and more bleeding compared to the people use warfarin. So this is the Kaplan-Meier analyzed event-free survival curve. So you will see the warfarin is much better than the Pradaxa alone. So this is why in the 4 months the study is totally studied, is stopped. And then they continue to monitor the patient until the 1 year. So the conclusion is Pradaxa was associated with a higher rate of ischemic stroke, 5% versus 0, and major bleeding, 4% versus 2% in 4 months of the study. And used dabigatran in patients with mechanical heart valve is associated with increased rate of thromboembolism and bleeding complications, and compared to the warfarin. There is no benefit and excess risk for the dabigatran. This is about the Xarelto in the patient with atrial fibrillation and needed anticoagulation post bioprosthetic mechanical valve. It's not mechanical valve. So the RIDO study is designed as a randomized trials compares Xarelto and dose adjust warfarin in patients with atrial fibrillation and prosthetic mitral valve. And the idea want to confirm Xarelto is no inferior than warfarin in the respect of the mean time until primary outcome, including death, major cardiovascular event, and major bleeding in the 12 months. So this is also involve probably 1,000 cases. Majority of people are a little bit younger because it's a valve change, so it's most of average is 59 years old. Again, major population race is a white population. And you will see the Xarelto is better than warfarin in the end of the study for the primary outcome. And Xarelto compared to the warfarin has less death from the cardiovascular causes or thromboembolism. The bleeding risk, Xarelto is less than the warfarin. The major bleeding is less, and the fetal bleeding, both group none, and major intracranial bleeding is not. But this is not a big group study, so this is probably the reason. So combine the subgroup analysis to see the bright outcome is favored. The Xarelto is better than the warfarin. Use the patient with AFib and post bioprosthetic mitral valve surgery. So conclusion for this is the patient with atrial fibrillation and the bioprosthetic mitral valve, Xarelto is no inferior to warfarin with respect to the mean time until primary outcome, include death, major cardiovascular event, or major bleeding in the 12 months. So you can use the Xarelto in the patient with atrial fibrillation and bioprosthetic valve. But how about Xarelto usage after the TAVR study? The hospital now do a lot of TAVR now. A lot of people, this is the clinical trial to enroll, is a little bit different. This group of patients is, they do the TAVR, but they don't have established indication for anticoagulation. That means they probably don't have less patients with atrial fibrillation. And they want to see whether you can use Xarelto post the TAVR compared to the standard of care, whether you can decrease the bleeding and decrease the thromboembolism. So this is totally like a 1,600 population, each group probably around 820 population. And the end point of the study is with the Xarelto compared to the warfarin, your death rate is high. So the study is if the patient has no indication for anticoagulation and you use Xarelto off the valve and try to prevent thrombosis, it looks like it's not having effect. And also the stroke risk is mildly increased too. And the primary safety outcome about the disabled bleeding and also high in the Xarelto group. This is the same thing. The red is the risk of the Xarelto, the blue is the anticoagulant agents alone. So combine the deaths and for any causes, Xarelto group is higher than the antiplatelet agents. So the concluding for this study is that in the 17 months, primary outcome of death and thromboembolism complications occur more frequent with Xarelto than the antiplatelet agents. So in the patient without established indication for oral anticoagulation after a successful TAVR, the treatment strategy includes Xarelto at a dose 10 mg daily was associated with high risk of death and thromboembolism compared to the, and also high risk of bleeding compared to the antiplatelet agents treatment. So this is the last one. This is about the anticoagulation. Doesn't matter Waffling, new anticoagulation agent. This is one to compare. See, if you use anticoagulation after the Taurus patient and the patient added Plavix, is benefit or not? So this is called popular Taurus studies. So it's a trial compared to add Plavix with no Plavix in the patient received anticoagulation, and the incidence compared the incidence of any bleeding and non-procedure related bleeding. So this is also a small study. It's involved 160 population in each group, and you will see the population group with oral anticoagulation and the Plavix has more risk for bleeding than the use oral antiplatelet alone. This is the death from cardiovascular causes and non-procedure related bleedings. You will see the oral anticoagulation plus Plavix is higher than the Plavix alone. So this is the death from cardiovascular event, ischemia event, is the same things. So the answer for this is patient underwent Taurus procedure who received oral anticoagulation already has incidence of serious bleeding over a period of 1 month or 1 year compared to the patient without using antiplatelet. And cardiovascular outcome is not inferior for the single Plavix treatment combined, but maybe superior if you combine the bleeding risk. So the answer for the valve with the new anticoagulation agents is Pradaxa cannot use in patient with mechanical heart valve. Xarelto is not inferior than Waffling in patient with atrial fibrillation and bioprosthetic valve. But Xarelto is high risk in patient without indication for anticoagulation after Taurus, and no benefit to add Plavix on top of any anticoagulation after a Taurus study. So this is my end of topic. Thanks everyone.